Hey y'all, it's me, Dr. Smina Rahman, Gyno Girl. Welcome to Gyno Girl Presents Sex, Drugs, and Hormones. Super excited today. I just finished my interview with Dr. Sonia Bahlani. She is an amazing friend and specialist in pelvic pain. And so we talked a lot today about, South Asian culture and pelvic pain, sexual pain, as well as we spoke about vestibulodynia, pelvic floor dysfunction, and when it's not either of the two and it's interstitial cystitis or painful bladder syndrome. Anyway, Dr. Sonia Bahlani's path to becoming a pelvic pain specialist was unconventional. She completed her OBGYN residency, saw people suffering from pelvic pain in silence for so many years, and she veered off the traditional course in a fellowship in the urology department, working with the pioneers in pelvic pain at Weill Cornell in New York City. She trained in this area and has a unique perspective on women's health issues. She graduated magna cum laude from undergrad at Virginia and did her medical degree from Virginia Commonwealth School of Medicine in Richmond. She completed her residency at OBGYN and New York Presbyterian Weill Cornell Medical Center. After her residency, she joined the Smith Institute following a fellowship in urology under the mentorship of Dr. Robert Baldwin, a leader and innovator in pelvic pain. She has been on multiple publications. She was the recipient of the 2014 Marinoff Career Development Award from the National Vulvodynia Association and been able to continue her clinical research interest in treatment of vulvodynia and sexual pain. She's part of the International Association for the Study of Pain, the American Association of Gynecologic Laparoscopists, and the American Urological Association. She's appeared on many publications, on many news outlets, and she wrote her book, the definitive book on pelvic pain, Dr. Sonia's Guide to Navigating Pelvic Pain. She has a unique, holistic approach to pelvic pain, sexual pain, and pelvic floor dysfunction, and you guys are going to love this discussion. So we're here to educate so you can advocate. So listen up, and this is going to be good.
All right. Hi, everyone. Thanks for joining me again. This is Gyno Girl Presents Sex, Drugs, and Hormones. I'm very, very, very excited today to bring you guys one of my BFFs from IG.
Yeah,
and
now real life.
Yeah, actually, and we'll talk about that. But but welcome to Gyno Girl Presents Sex, Drugs, and Hormones. My name is Dr. Smina Rahman. I'm a board certified gynecologist, practicing in downtown Chicago, specializing in sexual medicine and menopause. And I'm so excited to have with me Dr. Sonia Bahlani, who is pelvic pain doc in New York City. Her IG tagline is pelvic pain doc. You guys will get all her credentials on the show notes. But she's an amazing, amazing person. And it's interesting because we met on Instagram, 6 years ago or something. It was pre-pandemic for sure. Because before you started your practice, I remember. But anyway, we're going to talk all the things that you guys want to hear about and what she does and how she came to practice, in the sexual medicine space. And we're going to get at it. So thank you, Sonia, for coming to my podcast today.
Thanks for having me. This has been a long time coming, so I'm excited that we're
recording. But it's funny because I think we just started following each other. I don't want to say it was 2018 or something.
It was 2017 or 2018.
Yeah, it was a couple years before the pandemic, but I had just started getting on Instagram to advertise and educate for my practice and stuff. But
it would mean doctors weren't on Instagram.
Yeah.
So we were the only two that were, well, wait a minute, we do the same thing in Chicago and New York.
It's we're doing all the same things. And it was we just became fond of each other. And then we actually meet in real life at a couple conferences and we text each other quite often about, life and patients and everything.
Well, we have the same philosophy of care. I think that's really what it is we practice similarly and then we just happen to be similar people, but
exactly. So, you guys heard on the intro that, Dr. Sonia Bahlani, she has a book out on pelvic pain. She does a lot within the pelvic pain realm. When I met her, I think you were still working with some of the urologists that you used to work with. Is that right?
Yeah. So I used to work in urology and academics in New York at Northwell, where I did my fellowship for 6 years. And so then, taking the jump.
What your fellowship was in, by the way.
So, it's interesting because I'm a GYN by training. So I did my residency at Cornell in New York City. Then I went on to do my fellowship in urology, which is very non-traditional for the GYN.
Yes.
But I worked with, one of my mentors. His name is Rob Moldwin, and he really pioneered this space of pelvic pain in terms of interstitial cystitis. And then, you and I have trained with some of the gurus in vulvodynia and that kind of thing. And so it kind of bridges the gap in this field where people are often tossed around from doctor to doctor seeking answers. So I think that was the benefit of it. I was able to stay on in urology for a few years doing both, vulvodynia, pelvic floor, and IC work. And then ultimately went out on my own and seeing men with prostatitis, which is weird, but true.
Yeah. Yeah. For a gynecologist to see. Yeah, exactly. Because you and I are both board certified in OBGYN, no longer practicing OB, but, it's interesting because, patients always ask me, well, can you see my husband? I'm like, I'm not a urologist. So I can't. But like you have some training in that, which is wonderful.
Yeah.
Well, and then you decided at some point, I think it was right before the pandemic or during the pandemic, to start your own practice.
Right before the pandemic. So my husband and I joke that I decided to start my practice. There was a revolution, a pandemic, and basically the world was falling apart. And I was like, hey, let me start my own private practice in here. It seems like a great time to invest in my career. But it ended up working out. But yeah, it was a really kind of crazy time to go off on my own.
Yeah.
But I was so frustrated. I mean, I loved academics. You and I are both been in academics for almost our whole careers. And I think that oftentimes when you're so subspecialized, that's what you're geared towards is academics, research, seeing patients, but really evolving the field forward. But the problem with that when you're so clinical, like you and I, is that the patients don't get the support that they need when you're asked to see patients in 15-minute increments and they're patients in pain and you're trying to figure out what's happening and you're not given
and they're traumatized by the healthcare system over and over again.
And nothing's ever covered because insurance will say, no, I won't pay for a Valium suppository, but I'll go ahead and pay for oxycodone. And you're like, well, where were you?
Yeah. It's interesting because I feel like I always say when it comes to sexual medicine, menopause, pelvic pain, all the areas that women really suffer for years and years on end, the system is set up for us to fail as clinicians and them to fail as patients because, first of all, we don't get educated in this unless we go out on our own and get extra training or go to conferences and get extra training or work with the gurus that we have that kind of invented the fields. That's one way to get the extra training. It's not built into the system. And then the other thing is you are in a system and we were in academics. So you think hey, it's an academic medical center. You're going to get the best care. And I used to really believe that until I went into private practice and I realized, barring some examples, I guess, but as a generalization, if an academic center is still geared toward making money and the only way you can make money in an insurance-based model is really to see 30 to 40 patients a day, right? And to see the high yield stuff. So I feel like the system is so rigged against the patients and the clinicians to get successful in, treating them. And so that's why, unfortunately, throughout the years, women suffer the most, right? Over and over again.
And, at the same time, I think, like you said, it's rigged in both ways. But as kind of clinicians, we take the brunt of my insurance doesn't cover this kind of approach, and you're like, oh my gosh, I know. And that is I mean, I think we've both lobbied in Washington, D.C. I know I'm for IC and I think you have as well. I mean, there's only so much we can do to evolve this, but I always tell patients the biggest buildings in every city, like in New York, are the MetLife buildings, the insurance buildings, right? So
Blue Shield sitting right in downtown Chicago, Blue Shield.
Not forget where the intentions lie, but it's hard for also those kind of young doctors who are looking to get into the field,
right?
Because the field has become so popular.
Yes.
In recent years, with everyone wanting to do sexual health because they realize there's such a need for it. It's kind of like mesh where everyone starts doing it and then you start to get the complications because not everyone is trained. And I think that's where you and I kind of differ in the sense that we really have dedicated our careers to this, which is great. And I want more people to do that. And I know that many are, but it's almost like you have to be careful when you're seeking care because you just don't know,
Exactly. Because especially with the social media, the way it is, a lot of people fake it till they make it, that's the part.
It's great. And the thing with social media is awesome that everyone has a voice.
Yeah.
But it's a little bit complicated because not everyone should have a voice when they're not a specialist. Do you understand what I'm saying?
Absolutely. Absolutely. And I think that's where, we see the pitfalls, right? Because we'll see patients who are seen by really big names on the platforms, and they unfortunately didn't get the correct, navigation of care. And it's not always the case, but, sometimes it definitely is.
Hard. And it's hard because our population, for any clinician that sees pain or menopause or sexual health, is a vulnerable population, right?
Yeah.
So it's a population of patients that in general are doing whatever they can to get their needs met. And so it's hard to delineate that when you're there,
And I think you and I are South Asian by descent and Punjabi and everything. And we see a lot of, brown girls who come to us for various things. But sexual pain, I think, is such a big thing in our community, particularly when it comes to pelvic floor dysfunction and vaginismus. I think we talk about this all the time, is that, and I think I've told you the story that, like, it's so common that, like, people used to call it brown girl's disease, where I was like, we've heard this, right? And it's interesting because, what I'm talking about is vaginismus, which is involuntary contraction of the pelvic floor that can lead to worsening sort of hypertonic pelvic floor and dysfunction. But we do think there is a component of cultural, and social stigmas around sex involved with this. Mm-hmm. But I think I've told you the story how, like, when I was a resident and I've told the story on my platform many times, that my first year at internship, there was like a brown Muslim girl there going into labor, and the attending was getting frustrated because she couldn't examine her. And she was like, turned around to me after we left and said, "What's the deal with your people? They act like they've never had anything in their vagina." Have I told you that story before?
I don't think so, but I'm appalled.
Like, I was an intern. She was, a Caucasian woman. She turned around to me like she was like a, elderly intern. I mean, she's been around a long time at the university I was at. And she's like, "What's the deal with your people? They act like they've never had anything in the vagina." And I was just like, "What? Like, what do you say?"
That's horrible. But that also just furthers this stigmatization that, like, I mean, it's so interesting because you and I have talked about this before. Like, obviously there are cultural things that can be related to vaginismus, but ultimately there's genetic components, right? And so, like, it's not like it's shocking that we have a lot of South Asian patients, right? But it's also not that you can attribute it simply to our culture,
Exactly. And I think it's, the whole basis of, like, sexual shaming and all the things that happen in multiple cultures, right? I see Catholic patients who have it. I see Jewish patients, right? Like, all the spectrum. And some people don't even have a religious basis for it, but they have, like, sexual shaming in their household. So obviously that is a factor. But then you have other things, right? Like patients who are anxious, who are always clenching, or, someone who has an imperforate hymen, and the whole time, I mean, this has happened to me before, like, the whole time you can't examine them because they have such bad vaginismus. And this has happened at least 3 times in the last, I would say, 5 years that I've taken them to the OR for Botox injections because they couldn't even do it in the office. And I found an imperforate hymen. Like,
wow. Yeah.
So, I mean, it's not always, so I think that goes to our point that we all have our own, like, biases, and then we should check the bias before we.
But it also, I think, relates to the point that, like, yes, we definitely see a larger population of South Asians suffering from things like vaginismus, whether that's genetic or, as you and I would say, biopsychosocial. So there's a genetic component. There's always a social component. Also, there's psychological ramifications to these things. But ultimately, right, I think the hardest part in our population is that they often don't seek care. Do you know what I mean? Like, I have so many South Asian patients that are like, I always tell them about the genetic component. I'm like, if you look at the data, you're almost 7 times more likely to have it if you have a first-degree relative who has had it, And they'll be like, "Oh, I didn't even know that. My mom and I haven't talked about that." And then sometimes they come back and they're like, I asked my mom and she was like, "Oh no, she had the same thing." And it's like, yeah, I mean, like, definitely. And it's how sad at that age that they were just told to, like, breathe or, like, whatever.
Or that, like, the sex is going to hurt, so just deal with it, kind of thing. So they know it. normalized, right? Like, yeah,
Yeah.
yeah.
So,
And
but like, I wish more would seek treatment because oftentimes, or sometimes they come, like South Asian women will come see me and they'll say, um, but I don't like have a partner, so I don't think I really need to do this. And I'm like,
Yeah.
are you able to place a tampon? Are you able to
Yeah.
sit for long periods of time? And some of
Yeah.
those answers are no. And it's like, well, this is a quality of life issue that goes beyond
Right.
simply penetrative intercourse,
Yeah.
right. And then many times I'm sure you see it too, where you have these patients for years who have unconsummated marriages, right? That they're trying to have a baby now. And they're like, what do I do? Like,
Right.
now I've kind of got over the fact that like I'm not gonna have penetrative sex, but what do I do now? Like I need to have a baby. And so that's when
Today, and you're like, okay, well, this takes time,
Yeah.
right?
yeah, the longer you wait, it's like, 7,
Yep.
8 years. I think that was the longest I've seen someone that 7 or 8 years without like penetrative intercourse with their husband. And it was like, well, we have a lot of work to do right now. So let's like work on that. But yeah, I think and why do you think that? I mean, we see a lot of them, I think, because we're South Asian, right? I mean, maybe we understand the culture better. Like, why do you think they seek out care from you and I a lot?
I think for one, there's not a ton of specialists. So I
Right.
think you and I just happen to be two. And it's just fun. It's actually really just interesting that we're both of South Asian descent and like we
Yeah.
happen to go into this field. I'm
Right.
sure there's some sort of psychology there, but who knows?
Yeah.
You know? But I think the other thing is like it is definitely so normalized and stigmatized that it's hard to discuss. And
Right.
I think that seeing someone that you feel like you can relate to or that understands like kind of like your patterns or how long you want to take is really, really important because, the patient doctor relationship goes beyond just like physiologic, like here, let me put in a speculum or do this. It truly is like a collaborative partnership. And I think you have to be, especially for a topic like this that's so nuanced and so
Right.
delicate, it's important to be with someone that you feel like you can actually communicate with. I will often bring partners in. I mean, I'm sure
Yeah.
you do the same thing because
Mhm.
I'm like, this is not a one-sided conversation,
Right.
especially if you want to be with this other person and you want them to be a part of this journey for you,
Yes.
you know?
Absolutely.
And I know you always say this, and I always say this, the absence of pain is not pleasure. So, like,
Yeah.
even when we are treating your pain, if you're not having pleasurable intercourse, then we have work to do.
Yeah.
Like, I always tell me, I can easily treat your pain. That's going to be
Yeah.
no problem. But, like,
Yeah.
we have to work on all the other things surrounding it, too.
Yeah. And I think oftentimes, I mean, like even when you solve their pain, I think they're so mentally accustomed to pain for so long. That's where we get the hiccups, right? That's where they need the sex therapy and the other types of therapy because and not even just understanding their own anatomy. Like we can do that part, educate them. But I feel like I've done so much with some patients who for so long have lived with pain that like I'm like, no, like on exam, your vestibule is fine, your pelvic floor is beautiful. Like this is a good to go situation and they still can't get over the fact that they've had the pain for so long, right?
It's so true. I think what else I think is interesting, you and I have, I mean, we could talk for hours because we're so like similar and interested in this stuff, but you and I have talked about how in both our religions and cultures, we're both two different religions, two really
Mhm.
like I'm Sindhi, you're Punjabi, but we're still like, we come from two different cultures. But ultimately, sex was not shamed as it is now when you look at our culture from where it came from, or our religions where it came from,
Yeah.
right?
Yeah.
And so and now you're seeing this hypersexualization in India and this rape culture. And like, it really stems beyond like almost what we're talking about because it's been so ingrained in
Mhm.
kind of like what we do and just sex in general.
Yeah. No, and we should address this. This is such a horrible case that happened, just a couple days
Yeah.
ago or ago and called
The doctor. Yeah.
an intern. Do you have her name?
I don't know her name. I can look it up. It's in Kolkata, right?
I'll call it, yeah. So, yeah, she was a medical intern who, was raped to the point of her death, and so there's a lot of outrage about it. And I think it was in 2013 or 2012, there was that gang rape that happened in India too. And they thought this was the sexual tipping point over there. Not sexual, but I mean, obviously it was a violent tipping point. But I think that, where she was gang raped in public, was this in 2013? It was like 10 years ago.
Yes.
And so, we would have thought that, things would have changed and, sex was more like discussed in the households over there. But but this is happening with this medical clinician, this intern in India who was raped and to the point of her death. And it's just appalling, like the violence.
It's so common. That's the hard part, is that we're seeing it. Yes, there's these big cases, but we don't even know the intricacies of what's happening on a day-to-day basis there because of how stigmatized and shameful sex has become. Now it's hypersexualized,
Yeah.
And like, if we sat down and we taught our kids about sex and didn't say, "Oh, this is bad," or,
Yeah.
like,
Yeah.
we would be doing empower, you know what I mean?
And we all know that rape is really not even about sex. It's about, power
Right.
dynamics, right? But still, it's this underlying, I think, culture of shame and stigma that is so prevalent, which did not exist, to your point, before colonization, right? Like we think that all studies show before colonization of the Indian subcontinent, there were, the Muslims were speaking openly about, sexual intercourse in the context of marriage for the most part, of course, and the same in the Hindu culture and I haven't done much of the Sikh work, but I'm assuming it's similar. But I think that it was this puritanical view of what was, brought into the community that really shifted
Yeah.
the sexual.
And even with that remark about rape being about power, which is 100% true, it's the same regard when we're treating patients with vaginismus, in the sense that we're empowering them to take their care back into their hands. It's not just about sex. You know what I mean? It's not just about the penetrative intercourse. It's about
Yeah.
empowering yourself to be able to do whatever it is that you want to do. You
Right.
know what I mean? And so, like, it's just so interesting how it's all interconnected, and like, and so ultimately I think that that's why a lot of South Asians can seek you and I out too, because there is this other dynamic to it that you kind of have to understand to really be able to treat someone.
Right. And it's really just, I know people talk about cultural competence, but it's really cultural humility at the end of the day, right? Like understanding the underlying tones of the culture so that you can be humble toward the fact that like different people see things differently. And you're not going to say my way is better, but you're going to understand, where they're coming from. So they can speak to you and be upfront with you and talk to you in a way that, will make their care better.
Yeah.
But to your point about vaginismus and really being, like re-empowering them, I think also, I'm sure you've had patients who have for years said like, oh, but I mentioned it to my gynae a couple years ago when she was doing a pap smear that was very painful. And she said, or he said, have a glass of wine before sex, or, maybe your partner needs to do better. Someone told me that recently, like the last time she spoke out to her doctor about, pain with sex, her doctor had told her that her partner needed to work harder.
Oh my God. Oh my God. Oh
Yeah,
my
like
God.
great, stage 4 vaginismus.
Oh, like,
Yeah, gas.
yeah.
But I think, that's true. The trauma they endure over the few years that they trying to seek care is one that, prevents them from wanting to even go further with it. And do
Yeah.
you have patients that just kind of disappear sometimes when like they start vaginismus care and then and then like all of a sudden you're like, where did they go? Like you chat to them and then they're just like, I couldn't do it. I just, like
I, you
that
know,
breaks my heart.
it's heartbreaking, or patients that are just like, I've gotten this far, but I'm good with this, and that's fine. Everyone has their own, like, and I'm absolutely okay with that. But I think that's also where some of this comes into play, because look, any doctor can prescribe you hormones. Any doctor can give you medication. Any doctor can recommend a procedure. Not every doctor can do it, but any doctor can kind of sit
Right.
there and spew out. I mean, this is all data driven. This is, and anyone who gets this far in life is usually pretty smart and competent. But
Mhm.
like, at the end of the day, it's like me having a tennis racket and Rafael Nadal having a tennis racket. We have the same tools. It's just how you use them. If you're not using these tools as it works for your individual patient,
Mhm.
then it's not going to work. You know what I mean? And I think a lot of times people practice like a protocol, and that doesn't work for what we do, because that's not how this field works.
Exactly. It's biopsychosocial, but it's all very, very individualized to the
It is.
patient. Yeah,
Yeah.
totally agree. Let's talk a little bit about, bladder issues. As someone who treats, provoked vestibular, I think I did a podcast on now. you can have pain at the opening of the the vestibule, that little inner area of tissue between the labia minora and the opening of the vagina, the hymeneal remnants, up to the urethra, down to the perineum. And we talk about hormonally mediated vestibulodynia and how it can actually mimic some of the same conditions of interstitial cystitis, right? So we always look at the vestibule, I think, first, right, to see that if you're having persistent urinary urgency, frequency, painful urination, and all the things, and you can see that someone has hormonally mediated vestibulodynia, then you treat that, right? You give them the topical hormones, you might treat their pelvic floor and all the things. But then some of those patients, it doesn't work for because it's not hormonally mediated vestibulodynia, right? It's painful bladder syndrome or interstitial cystitis. So can you talk to me about how you approach that once you realize, okay, their vestibule's fine now, their pelvic floor is fine now, let's go from there?
I mean, I think that's the most important part about having holistic care is being able to kind of like take a look at all of these different factors, because 80% of patients who walk into my office with the diagnosis of IC actually have concomitant pelvic floor dysfunction or some sort of vestibulodynia, whether that's hormonally mediated or neuroproliferative or whatever. Okay.
Right.
But so what is IC? So in the United States, when we look at like the NIDDK data, we call interstitial cystitis bladder pain syndrome. Okay. And in Europe, they call it painful bladder syndrome. It's just nomenclature. It doesn't really matter, but it does a little bit in the sense that like the whole point is that phenotypically, this is a bladder centric diagnosis, meaning that it's coming from the bladder and it's not coming from the nerves. It's not coming from the muscles.
Right.
So what causes IC? We don't really know. We believe that there's some sort of chronic inflammation. Oftentimes there can be autoimmune things going on at the same time that lead to a degradation in the gag layer of the bladder. And the gag layer of the bladder is called the glycosaminoglycan layer. It's the protective layer of the bladder. And if I ever want to make an analogy, I say it's akin to leaky gut, right? So what happens is the chronic inflammation creates holes in this gag layer. It's like a protective coat. So it's like wearing a raincoat outside and now your raincoat has all these holes in it. You're going to feel the rain a lot more, right? So people with painful bladder syndrome feel everything a lot more, whether that's when their bladder is full, whether that's pain from their bladder or pain with bladder filling or pain after urine. So the biggest symptom when you're looking at a patient for or evaluating for interstitial cystitis is number one, that it's a clinical diagnosis. So people always ask me, do I need a cystoscopy to be diagnosed with IC? And the truth is, if you look at AUA guidelines, you do not. Most people will do a cystoscopy because when you are evaluating for interstitial cystitis, you're dividing these patients into two groups. You're dividing these patients into Hunner's lesions and non-Hunner's lesion patients. And so 80% of patients with interstitial cystitis have non-Hunner's lesions. So you look in their bladder and it looks completely normal. That doesn't mean there's not something going on, but that is the definition when you're looking at why you would even do a cystoscopy. 15% of patients will have something that's called a Hunner's lesion. This is an area of inflammation inside of the bladder that we can see visually, okay? It looks like a star red pattern. In general, if you look at the data, this is most commonly found in patients over the age of 55. So what we believe is that this chronic inflammation harbors in the bladder and often doesn't provide visual evidence until they've had it for a very, very, very long time. The reason that you care about this is because you're going to treat patients with Hunner's lesions and non-Hunner's lesions very differently. So patients with Hunner's lesions, you can inject with like a topical steroid cystoscopically. And that oftentimes really helps their symptoms of pain in their bladder, persistent urgency, and frequency, although the vast majority of these patients do have concomitant pelvic floor dysfunction. So you're kind of working with both. Patients without Hunner's lesions, you're going to treat differently. So oftentimes those patients are the patients that will benefit from things like hydroxyzine, like low-dose anti-inflammatories, amitriptyline, nortriptyline, bladder installations, Rapaflow. So we have a ton of different options with these patients. They just don't fit into the box phenotypically like Hunner's lesion patients.
Right.
And so it's important because IC is something that both women and men have. the vast majority of people will try to treat IC with diet alone, which, if you look at the data, has a ton of selection bias. So it's one of those, and I can say that because I helped to write that data. So like, you write it and then you review it and you say, okay, like this was faulted in this way. But because essentially it's a retrospective study that we used questionnaires. Do you know what I mean? And so ultimately you selected for the patients that were diet sensitive when you did the questionnaire.
That's true. Yeah.
And the only reason I bring that up is because most patients who come to my office with IC are like, I've done the diet. It didn't work. So does that mean I don't have IC? And it's just because that's the most common thing that they're given to try to help them when the data is just very faulted. And a lot of people with IC are not diet sensitive.
Right. Right. So you have a patient. So tell me how you walk through this. So you have a patient that maybe has had a diagnosis of IC, but jumped around from gynae to urologist to gynae to urologist, or you're a gynecologist, whatever. You examine them, right? You're making sure their vestibule is is it coming from the vestibule? Is it coming from the pelvic floor? Is it both? And you treat that, and maybe it doesn't help. Do you go straight to the cysto at that point, or how do you work out those patients?
So I think it depends on their symptoms. So number one, if the first visit, like you said, I'm doing the Q-tip test, I'm testing their pelvic floor, I'm asking questions like, what are your symptoms? And if they're saying things like frequency, persistent urgency, pain with bladder filling, the feeling of incomplete emptying, in general, you have to peel the onion. So first things first, if their pelvic floor is hypertonic and they're presenting with bladder-based symptoms, I'm going to treat the pelvic floor,
Right.
because that's my money shot.
They're always hypertonic, right? Because they're usually clenched.
Yes.
I Twitter or your ex comment that they were like, if you're not clenching your pelvic.
I mean, like, if you don't have pelvic floor dysfunction in this day and age, I don't know. I don't know.
You are.
So I'm targeting their pelvic floor. Now, after I target their pelvic floor and they come back, it's really going to be contingent on their symptoms. So if they say to me, I really felt like my frequency's gotten better, perhaps even my persistent urgency, but this pain with bladder filling, it's not going anywhere. It's still there. And it really hurts when my bladder fills. I feel a lot better after I empty. But this pain is searing. It's driving me insane.
Yeah.
Then I have two options. So number one, I'm not just going to jump to a cysto, although at some point I'm going to have to do a cysto, but we can try other remedies like oral medications, things like Urabel, Pyridium. So if I numb the bladder, do they get relief? Do you see what I'm saying? And if that's there, then I know that something is coming from the bladder. Oftentimes I will say, let's look inside. Let's make sure I'm not missing something. Number one, a Hunter's lesion, but number two, even some type of bladder tumor. Although less common, it is always, we are looking for these zebras, right? And so we have to make sure we're not doing something that could be harmful.
So in academic medicine, we see a lot of zebras, so we're used to seeing all the zebras.
Right.
Yeah.
And so we do a cystoscopy. Everything looks okay. At that same time, I'm going to put in an installation. And normally my installations are composed of things like lidocaine, marcaine, always a coating agent like heparin, Almiron, hyaluronic acid, whatever you want. Like, in Europe and the US, we use different entities. Oftentimes an anti-inflammatory, like a little bit of steroid kind of log, something like that. And if the patient gets symptomatic relief, even for an hour, you know what I mean? Or for a day, that points in a direction for me. Because if your pain is coming from your bladder and I numb your bladder and you get relief, then automatically this is called an anesthetic challenge and you're diagnosed with interstitial cystitis.
Yep.
I think the biggest misconception that we have that I see as a one entity thing, I see as a spectrum, right? And so, you don't have to be like 100% here or 100% there. Like oftentimes there's this middle ground.
Yeah.
And that's when patients get placed on things like overactive bladder medications, Myrbetriq, that kind of stuff. So, that's kind of how I'm going to approach this situation.
Gotcha. That's wonderful. Yeah. I mean, I think it speaks to, just how we always say that, we're just not enough. I always say that's the problem with women's health and research, is that we don't have enough research in women's health. That's why we have so many syndromes and disorders, right? Like things like
hypertension and diabetes are diseases because we know exactly what's up with them, right? But when there's syndromes or disorders, like we have to just put pieces together and assume that we know like something and, diagnosis of exclusion or clinical diagnosis, it's like frustrating, right? It's like with endo, like, yeah, I mean, surgically, that's how we would diagnose it, but does everyone need to go have a surgical diagnosis? Like not always, right? They sometimes, most of the time we go clinically. We try to treat your symptoms clinically, like what's happening, with your dysmenorrhea, with your pelvic floor, with your sexual pain. But it's frustrating because these are disease entities that are really like system based. Like some of them are affecting more than just the bladder or just the bowels, like for instance, with endometriosis, right? And it's just like, I know both of us, we're not endo trained surgeons, but we treat endometriosis from like pelvic floor perspective and, with hormonally based remedies and all the things, but it's very
And
frustrating.
truth, I mean, but and that's the other issue kind of I find that when you're treating women's health is that often it's not a one source thing, and so everyone wants it to be like this single entity cause. And for the vast majority of patients, the reason it's so complex, it's because it's a little bit of this and a little bit of that. And if we're not treating everything concomitantly, then you're not going to get the relief that you so desire.
Right.
And I think that's what becomes frustrating too, is that everyone wants a single pill or a single procedure. Bam,
Right.
I'm done. That's
Yeah.
not the nature of the game,
Yeah. And that's the frustration in general, I think, when it comes to people that just want protocols or cookie cutter medicine. Like, that's why it's important for, like, when you go to a specialist, that they do have the time and the energy and the resources to get you to the people you need to see, that they have a team of people working with them, because none of this is cookie cutter medicine, right? It's not just a one size fits all. It's very nuanced.
It's very nuanced, and it's very like we are looking at every cause in order to give you true 100% relief if we can.
Right. Yeah, exactly. We want to give you as close to 100% relief as we can get, and that's our goal. We want to get you pain free, but also seeking pleasure too, which I think is always the challenge for patients who have suffered for so many years.
Absolutely. Absolutely. And I think it's great that you have this platform and you use it to educate people, especially, oftentimes South Asian patients, all patients in general, but there is such a lack of information for specific patients coming from different places. So I think even just being able to access the information, knowing they're not alone is huge.
As we wrap up, Sonia, tell us, like, what advice would you give like a patient who, has been, to multiple like, what are the things that you tell them to look for when you're looking for someone that they can that can help them, or to, at least guide them in that direction? Like, what kind of closing advice would you give to our listeners and viewers?
Number one, I think that be an advocate for yourself, because I think with this field, often like you said, and I hate it. I hate that people are gaslit and they're just automatically told that nothing can be done, or that it's in their heads, or that, I think like patient advocacy is really important. It's something that you and I do, but I think patients themselves need to be their own advocate. They need to have,
you got to save yourself.
yeah, and come in with your, like have your documents together. Like I always tell patients before they see me, I ask them to send me all their previous history, because we're not reinventing the wheel here. We're looking at the nuances to see what didn't work and why they didn't work and what we can do to actually get them to effective care. And for me, I don't even do general GYN. So like my goal is to get them better and then get them moved on. You know what I mean? So like number one, being an advocate for yourself. Number two, I do think that we know our bodies more than we give people credit for. So like, point being that like, if someone's just telling you that like, this is not it, and you're convinced that there's something else happening, like even with recurrent BV or like recurrent symptoms, like there are people like you and I, and there are different like sites and stuff where they can connect you to doctors local to you. Like seek out those sites, like, ISHWISH, NVA, IC Network, there are all these different like conglomerates that can help direct you to specialists like you and I who can help.
Yeah, absolutely. I mean, I think those are very important. And I think that, my tagline is like, I'm here to educate so you can advocate. Like, we want to educate you so you can go and advocate for yourself, right? So that And I actually, like, don't you hear like on certain groups, like where docs get frustrated because they Googled so-and-so and like whatever. But I actually love it when patients come like really well educated and like they know their body and they like, I had a patient recently that came to me and she was like, I read, the book by, the Goldsteins and Joe Kraft, the one on When Sex Hurts. I read this, I did this. I think I have neuroproliferative vestibulodynia. And I said, okay, well, let's check it out. I'm glad that you know what that is. At least you have the vocabulary for it. And actually she did. She was totally right. Like she had been through 7, 8 years of like lack of treatment. And she was like, I figured out, like, I know that it's the vestibule, not the, vagina, like she had figured it out. So I actually love that. And I know you do too.
Yeah, absolutely. I love it. And I think that many patients are able to self-diagnose, especially when they've been through the gauntlet like this. And we have to like give that like, and I always tell patients, Google. Oftentimes Reddit rabbit holes can be scary. So just ask me, you know what I mean? Like if you have a question, that's what I'm here for,
Yeah.
because oftentimes just going down these rabbit holes, that's what can have it become so like stressful, anxiety provoking.
Right. Absolutely. And sometimes, and we say this, I think, to our patients, like especially with with the PGAD patients who are really struggling for a long time, or these other pain patients, sometimes they go to these groups where like there's a lot of people telling their stories, and sometimes it's really helpful. And sometimes it's actually like, I need to step away from that because there's a lot out there that is actually scaring me now,
Yeah.
It's like just your body. It's not like social media. Like sometimes you love it and sometimes you
I feel like, yeah, exactly. There's a time and place.
yeah, place, right. But just, and I think to your point, what you said is like, women know their bodies better than they think. So I love that you said that like, listen to your body and understand what you're going through.
Yeah.
Well, thank you again, Dr. Bahlani, for coming to these podcasts. Gyno Girl presents Sex, Drugs, and Hormones. Remember, I'm here to educate so you can advocate for yourself. Please tune in next week for another great episode. And please like and download my podcast so I can get, more people to listen to it. Thank you so much.
Second, please subscribe to this podcast. I'd love for you to be a follower and learn as much as you can about the things that we're going to talk about with all the people on our journey. Please review us on Apple or Spotify or wherever you listen to podcasts. These reviews really help. Review us, comment, tell me what else you want to hear. To get more information, my practice website is www.cgcchicago.com. My website for Gyno Girl is www.gynogirltv.com. My Instagram is Gyno Girl, so please follow me for some good content. Additionally, I have a YouTube channel, Gyno Girl TV, where I love to talk about all these things on YouTube. And please subscribe to my newsletter, Gyno Girl News, which will be available on my website. I will see you next time.